I'm Dr. Gary Kupfer. I'm a member of the Division of Pediatric Hematology, Oncology at MedStar, Georgetown University Hospital. I take care of patients with all different kinds of diagnoses within the realm of pediatric hematology, oncology, both those that have cancer as well as those that do not have cancer. And in particular, I specialize in patients with bleeding and clotting disorders, as well as patients with bone marrow failure disorders, which results in aplastic anemia. When one asks me about why I do what I do, it's a complicated answer. It obviously starts with the ease, ability, and motivation to just simply engage with children, to get down on the floor and play, to feel comfortable talking to their parents. And then beyond that, the environment of academic medicine is one that really allows the opportunity for the immediate gratification of caring for children and the patient themselves, together with the intellectual pursuit of more knowledge, science, culminating in advancing therapies for the broader swath of patients. The exciting part about doing what I do is that every day I could be sitting with a patient on one hand and then walking over to my laboratory to think about the lessons learned from that patient towards advancing therapy through a particular experiment going on in my laboratory. That, at its very base, is what really is highly motivating and pleasurable in my day-to-day job. I'm really part of a group that has a really extraordinary amount of depth and breadth. For hematology oncology, one has to have that really strong toolbox of skills. Number one, I tell people and I remind people that hematology oncology is really, these are sets of diseases that really affect patients from head to toe. It's not just one isolated part of their body, and these are patients that can get quite ill. And so it really requires a true physician capable of taking care of those kinds of issues. Number two, while cancer diagnoses often attract a great deal of attention, non-cancer blood-related diseases far outnumber cancer diagnoses and are quite common out there in the community. So there's really quite a need for people to look after patients who have blood-related diseases of all different varieties. We're really more than about just simply writing the prescriptions, hanging the medications in clinic, but really place a huge emphasis on the psychosocial care of our patients with a collective team of physicians, nurses, child life experts, art therapy, social work, psychology, and psychiatry. We all have to work together to take care of patients in both the medical as well as the non-medical sense. One of the most common ways we get involved with patients with clotting disorder predisposition syndromes is when there's been a family member who's had blood clotting, or a member of the family in whom we've identified one of these genetic syndromes. Then we'll want to understand, does that patient have a genetic cancer, clotting predisposition? When we identify that patient, our goal is to get involved very early with the establishment of good habits. Number one, it's about those habits of avoiding the environmental risk factors that go along with a predisposition to getting a blood clot. I mentioned before that one of those predispositions to getting a blood clot is age. Well, we can't do much about that. In fact, we want people to acquire that blood clot risk. However, there are things that we can do something about. We can preach the importance of avoiding the habit of smoking. We can avoid provision of estrogen in terms of birth control. And luckily, there are very many good birth control methods that avoid the use of estrogen. We can advise our patients that when they go on trips, for example, on the airplane or in a car, to maintain good hydration, to take frequent breaks, and get up and stretch their legs. And as I remind patients that if they're maintaining good hydration, they're going to be taking some more than frequent breaks to the bathroom, and thus stretching their legs that way. For us as physicians and medical care folks, we have to be cognizant of these patients as well. For example, if they are going for any kind of surgery or being cared for in the aftermath of significant trauma, they may be laid up for some extended period of time in bed or with a big cast on their extremities. In that situation, they may need some short-term anti-clotting medication in the form of blood thinners to prevent getting a blood clot altogether. The most important thing is that we've acquired that knowledge ahead of time so that we know going into these situations that patients can be protected and most importantly, having these blood clots prevented. One of my interests in the field of hematology oncology are a collection of diseases that I would term genetic predisposition diseases. Often these particular disorders take the form of some other either birth defect or a disorder in the realm of blood formation. So there's usually some kind of clue that this patient has some underlying genetic problem that brings them to medical attention. In this particular case, it's often known from experience in biology that these patients can have a predisposition or a greater chance of getting a cancer as a young person. Many of the diseases that I take care of affect the bone marrow, and thus anything that affects the bone marrow tends to have an effect also of greater chance of getting a leukemia. So as an example, I will progressively over time care for these kids, not only in their immediate needs of making sure that their levels of red blood cells, platelets, and white blood cells are adequate, but also in regular examination of the bone marrow to be sure that any subtle or very apparent changes have not occurred that make me worry that leukemia might be around the corner. In addition, some of these diseases that show up as blood-related in early childhood or even throughout childhood can often show up in other ways as young adults. For example, I still get called over to see young adult patients in the adult oncology clinic who form unusual cancers in their 20s and 30s, such as diseases and tumors of the head and neck. So in concert with my adult colleagues, it's the understanding of the genetic basis of cancer, which gives us clues to trying to preempt and provide for early detection of cancers in those patients we identify as being at risk. The relationship of blood count abnormality and cancer is definitely there. However, I try to remind patients that just because someone is anemic or has a disorder in one particular blood cell type or another is certainly not cause for alarm. Far and away, most of the time, any abnormality like that turns out to be nothing or resolves on its own. There are a whole lot of different explanations for being anemic or having a low white blood cell count that happens temporarily, such as a virus or sometimes drug. But in a small percentage of times, it can be a clue that something more sinister, more serious might be going on. Often that won't become apparent right away, but for that reason we have to follow patients along for a period of time till things become more obvious. For many of the diseases that we take care of in hematology, oncology, these are lifelong disorders. They're genetic. Patients don't stop having them just because they reach a certain age or a certain threshold in their lives. For that reason, one of the biggest things we do in clinic is simply provide education. It's so critical that these kids, as they get older, acquire a knowledge of their own medical care, and frankly, that's empowering. It helps them to be their own advocate, because for sure, they're going to be leaving the house, they're going to be going on to college, careers, whatnot, their own families. We want to impart upon them a basic knowledge of their own underlying medical issues, because obviously they'll have to speak for themselves. This is why we're very upfront with talking to young girls about their menstruation. We want that to be a very natural thing, because sooner or later they're going to be thinking about starting a family. How do I work my way through that? They might be injured or considering a surgery as a young adult, and therefore have to consider, imparting the idea to their caregivers that I have a predisposition to getting a blood clot. You need to take care of me correctly to avoid getting a blood clot. And while legally we think about pediatrics as up to the age of 18 or even 21, we know from a biology point of view, these are diseases that are really transitioned throughout young adulthood. And for that reason, we manage and follow many of our patients all the way through their 20s, even their 30s. In our bloodstream, we have protein factors and specialized blood cells called platelets, which all come together to form the blood clot. Just as we want to stop our bleeding when we cut our finger, when we chop up an onion in the kitchen, we don't want that blood clot to go everywhere. And we got to put the brakes on that clot, because too much clotting is as dangerous or as bad as too much bleeding. So bleeding and clotting are very much in equilibrium. A defect on one side will lead to too much bleeding, but also a defect in the other side will lead to too much clotting. Most people out in the community have their first encounter with a clotting problem, with a very common example of an elderly person who falls and breaks their hip and is thus laid up in bed or on the couch at home. And then with a resulting problem of forming a blood clot in the leg, which will pop up to the lung, and very often that event will be fatal, which demonstrates that that is an acquired risk of getting a blood clot in the form of immobility and in the form of age. There are other environmental risk factors for getting blood clots, such as smoking, obesity, immobility. More importantly for children, there are also genetic risk factors for getting blood clots, because most children are not smoking. Most children have not gotten old enough where age becomes an independent risk factor. And most prepubertal patients are not on the birth control pill. In other words, being provided environmental estrogen to control symptoms. And in that respect, there are numerous genetic predisposition alterations that result in clotting risk. That can become manifest by a clotting event which occurs in a patient, and thus identifying that patient as being at risk for developing future blood clots. Another way we might discern that patient by being at risk for getting a clot might be because they have a sibling or a parent who's had repeated blood clots. And that might give us an early clue that there's something genetic going on. By understanding that particular risk, we can take better care of the patient going forward by taking certain precautions so that they will be at lower risk even with their genetic makeup, but result in a lower risk of getting a blood clot going forward. In a pediatric patient, a clotting event can take many different forms. They're definitely very unusual because of age being an independent risk factor. So we don't see a ton of blood clots occurring in children unless there's something else going on. One may be the combination of a genetic risk factor for having a blood clot coupled with taking the birth control pill in pubertal girls. In that case, it might be the development of a painful swollen leg. It may be the development of chest pain and shortness of breath. Those would be the most common versions. Other versions in children who are undergoing complex medical care, such as cancer patients undergoing chemotherapy, might be the dysfunction of their intravenous line. Often children with cancer need to have an intravenous line placed in their chest for the administration of chemotherapy and other medication. For those children, just having that piece of plastic embedded in their vein, the large veins surrounding their heart, is yet another risk factor for getting a blood clot. And when a blood clot forms around that line, those lines can stop working, and that can often be yet another clue. We as pediatric hematologists, oncologists, are usually very well tuned into that problem. In addition to the central line in the chest, some of the chemotherapy drugs we use also cause disordered coagulation. That means an imbalance in this equilibrium between bleeding and clotting, and can promote either clotting or bleeding. Clotting disorders are treated in a number of ways, and some of it depends on what we would say the functional effect of a particular blood clot. If a blood clot is formed but is not completely clotted off a particular vein or blood vessel of the body, it might be simply the provision of a blood thinner for some period of time, either short-term or long-term. It might be intravenous, subcutaneous administration, or it might be a pill. If a major blood vessel has been blocked so that blood flow is obstructed, for example, to the lower leg, that might necessitate the intervention of either other surgical approaches as well to help literally remove that blood clot from the blood vessel in order to restore normal blood flow. We know that over the long haul, these patients who do get blood clots are at greater risk for several things. Number one, they're at greater risk for getting another blood clot in the future. And of course, these blood clots have the potential to move from the lower leg up to the lung, which can cause serious, if not fatal, outcome. In addition, the damage to the veins of the legs and arms actually can result in decreased functionality of the extremities, where the circulation is poor. There can be skin breakdown, infection, chronic swelling. So these are reasons why very often, depending on the severity of the blood clot to begin with, will necessitate or dictate how we choose to intervene, either with medical and or surgical approaches. Young people who want to go forward with having a baby, becoming pregnant, with either bleeding or clotting disorders can do so successfully with proper care. Generally speaking, patients we've identified with bleeding and clotting disorders need to have a partnership formed between a hematologist as well as generally a high-risk obstetrician. In doing so, we can undertake a couple of different goals. Number one, in a woman who wants to get pregnant or is pregnant who has an underlying clotting disorder, we know that particular person is at greater risk for getting a blood clot during her pregnancy. She's also at greater risk for having a miscarriage during that pregnancy as a result of the clotting disorder. And very often, when we've identified a patient up front who has that risk, that patient will undergo what we call prophylactic therapy with the use of a blood thinner throughout pregnancy. On the other hand, a patient who has been identified with a bleeding disorder will require specialized care as well with a hematologist, but in a different way. For that particular patient, we will have to have a very detailed, careful, and well-communicated plan in order to make sure that patient's labor and delivery will go safely for the mom, but as importantly, will undertake and stimulate the proper care of the newborn in the aftermath of delivery to ensure that, number one, we've evaluated whether that newborn baby has a bleeding disorder, and are there any effects from having undergone delivery in that baby that we have to worry about in the short run. One of the more common ways I come across new patients with bleeding issues is via referrals or when parents bring in their young children with nosebleeds. Obviously, nose bleeding is not all that unusual in a little kid. Young little fingers are often making their ways up noses frequently. But this is where getting a really good history comes into play by talking with the family, understanding what the frequency is, what the amount of bleeding might be. And you begin to understand patients who have something going on are often having a nosebleed a week, 2 nosebleeds a week, 3 often, and you realize it's just more than the occasional bit of trauma that occurs. And often taking a step beyond that, we have to get lab work to really further define what's going on. On the other hand, one of the very common ways patients have nosebleeds is simply because of allergies. Or, as you could expect, some of the more common bleeding disorders may actually happen in the same kid in which there are allergy problems as well. And the combination of those two things can make the nosebleeds even worse. So when I'm visiting with a patient and their families in clinic, I'm actually taking a very significant amount of time to describe exactly how to manage a patient's nosebleeds from purely an allergy point of view or just treating symptoms, keeping a nose moist, treating with over-the-counter allergy medications, putting a humidifier in the room at night so we keep that air nice and humid and keep the nose from drying out, putting some Vaseline in the nose so we don't have that winter air drying out the nose. And then we'll see what the laboratory testing shows. Does that little kid have a true bleeding disorder or not? And in some cases, many in fact, that patient doesn't actually have a bleeding disorder and really just had an allergic reaction going on in the nose, which is all too common, as we know. Certainly, bruising is a very common complaint that comes our way in the evaluation of and consideration of a bleeding disorder in a child. On the other hand, we who are, especially those of us who are parents, understand that there probably isn't a child around who doesn't have a bruise of one kind or another, especially in the area of between the knees and the feet. I would say just about every child I know of a certain age has a bruise on that particular part of the body. Again, it's one of getting a history and understanding what really has been going on. Are these bruises that are showing up in other parts of the body? Are these bruises that are just showing up for no reason at all? Or are they clearly related to a rambunctious 5-year-old who's jumping around off of heights and getting into scrapes and all kinds of trouble all the time? So one has to understand context to really understand how meaningful some of these symptoms are. One of the most common things we get asked about is simply, can my kid participate in regular sports activities? The very first thing I tell people straight off the bat is that in almost all situations they can play sports. The question is, how do we manage that? And that management takes the form of a couple of different avenues. Number one, of course, we want to figure out with as much specificity as we can exactly what is the underlying problem. Because once we know that, then we can know, in the case of any kind of unexpected trauma, the best way to manage it, either with a particular medication or, in certain circumstances, do we need to restrict the level of activity going on. Above all, we really have to just have a good game plan, know what to do. In the case of my 15-year-old driving for the basket and having his legs taken out from underneath him, how are we going to react to that when he lands on his back? Are we going to have to rush him to the hospital? Or can we just worry a little bit less about it and maybe just put some ice on it and treat it as we might treat any other kind of minor trauma? It's all about knowing ahead of time, having that knowledge so then we can know the right reaction, the right level of caution, and just what we have to say no to, but more importantly, what can we say yes to? In general terms, my own level of saying yes and no really depends on the level of traumatic activity associated with a particular sporting activity. I would say no, in the case of bleeding disorder patients, to activities that what I would call purposefully violent, boxing, American-style football, where the intent, obviously, is to hurt the other person. In that case, I really do rule out those particular activities. I, again, stress to the families that that rules in virtually every other sport. And in those cases of all those other sports, it's really our goal together with our families and patients to come up with a good game plan. And once we have a good game plan in place, then things can proceed much more safely. When we think about going to the dentist, we know that it's a very common event for all of us, with most of us going to the dentist at least twice a year for cleanings. And in the course of doing that, all kinds of things pop up. Fillings, braces, wisdom teeth coming out, other extractions. And we know that in the case of bleeding disorders, patients bleed to varying degrees with all of those types of activities. Number one, I address the need for good oral hygiene. That means brushing a couple of times a day, flossing. I particularly point out flossing because flossing is really important for good gum health. If you can imagine, brushing does not do a very good job at removing all the food particles at the base of the teeth next to the gum. When all that food gets left behind, it creates a very rich environment for bacteria. All that bacteria results in inflammation of the gums. When tissue gets inflamed, they're more likely to bleed. And when you have a bleeding disorder, you're more likely to bleed. Put that together, and you can have some major issues going on in the mouth. Number two, we do a ton of coordination with dentists in the community. When I have a patient who I know I learned from the dentist or the patient is going for an extraction of one kind or another, we generally need to make some communication with the dentist in order to design a good plan that will result in a very safe and effective procedure. If it's a simple matter of removing a baby tooth or a little filling, well, that requires minimal intervention. In the case of wisdom teeth, however, wisdom teeth, as you may know, they have roots this long, so the amount of trauma created by their extraction is significant. It may mean I want that surgery done right here, where I can jump over and make sure that that patient has his needs addressed. Or it might simply mean that I can coordinate even more intensively with someone in the community to ensure that we have the proper medication ordered, the right follow-up care delivered. Something as simple as not having the extraction done late in the afternoon, have it done early in the day, so that if a problem does arise, we can address it much more effectively than in the middle of the night. Not have it done on a Friday. so that we're dealing with a patient during the week when clinics are open and not in emergency rooms. So just trying to put together both a medication plan, but also a common sense medical delivery plan so that these types of interventions are done safely. Heavy menstrual bleeding is a very common manifestation of a young lady with a bleeding disorder. First, though, the most important thing is to really tease out, is it truly heavy bleeding, or is it what we call disordered menstruation, or in other words, dysmenorrhea? And I actually get right down to nitty-gritty questions with my young girls who come to my office. I first apologize very respectfully. I acknowledge the fact that I'm a guy and I'm asking you all these personal questions. And that usually disarms my patients just enough that I can start getting some straight answers. But I ask, do they use pads or tampons? How many times a day are you changing? How many days does your period go on for? Is it more about the crampiness, or is it more about the bleeding that's the most problematic? And very often by teasing this out, you can gain an appreciation for it's really more about the overall symptoms of menstruation rather than the bleeding. And in that case, the treatment is often a little bit different. You're not really focusing on the bleeding, but rather the symptoms and regulation of menstruation. But of course, patients with bleeding disorders will have greater degree of menstrual bleeding. That degree of increased menstrual bleeding leads to other problems, such as iron deficiency anemia, which of course causes diminished energy, decreased thinking, more poor school performance. So all these things are interconnected. And very often we have to design a treatment plan which will help to get that bleeding under control. With respect to designing a treatment plan for a girl with heavy bleeding, one of the go-tos is actually hormone control in the form of birth control pill. And that will often make parents of an 11-year-old kind of be taken quite aback by that comment. And I really remind patients that for our patients with bleeding disorders, these are not birth control pills, these are bleeding control pills. I would say for probably 90% of our patients with bleeding disorders, all we have to do is provide hormone control in order to get their bleeding under control and thus be much more manageable and avoid all the complications of heavy bleeding.